I would like to invite our first presenter to the stage at this time. Our first presentation is titled, Exploring Home Field Advantage, Do Interns from the Same Institution Perform Better on the Milestones? Presented by Dr. Sierra A. Haju at the University of Cincinnati Medical Center.
Good morning, everybody. All righty. My name is Dr. Sierra Haju. I'm a third-year emergency medicine resident as well as a rising chief at the University of Cincinnati. And as mentioned, today I'm going to be talking about our research study, Exploring Home Field Advantage, Do Interns from the Same Institution Perform Better on the Milestones? I'd like to give a very big thank you to all of my co-authors. This project would not be possible without them. And I'd like to thank them for giving me the opportunity to be speaking in front of all of you today. Here are our disclosures. I'm sure probably all of you are familiar with this concept of the home field advantage. It refers to a tendency for generally sports teams to win more frequently at their home venue. And although some people might think it's myth, it is actually something that's been borne out into reality. It's been attributed to a wide variety of factors, including decreased travel fatigue, increased familiarity with their home venue, crowd support, and even referee bias too. The home field advantage, though, is something that has actually been shown to exist in other realms as well besides sporting, including business, law, and education. However, very little is known about whether this exists in graduate education, particularly graduate medical education. And our group sought to see if this existed in graduate medical education and emergency medicine. We wanted to know if residents who were on the home field, so matriculating into programs that were affiliated with their school of medicine, did better than their peers that were coming from other places. Colloquially, we might call those people the visitors. In starting this, we knew we needed to think a little bit about what might drive applicants to match at their quote-unquote home field. There's a bit of a paucity of data on this relating in the emergency medicine literature. However, in recent years, the NRMP has been surveying both applicants as well as program directors alike to learn about the factors that go into their rank list. I've listed the top 5 factors for each. You can see that a significant longitudinal experience, such as exposure to a department in medical school, might greatly impact these factors on both sides. I myself was a home field resident. I went to the University of Cincinnati for medical school as well, and I can confidently tell you that my rank list had a lot to do with my time in medical school. We sought to theorize that if a home field advantage existed, why it might exist. Essentially, a home field might ameliorate some of the challenges experienced in the transition from medical school to residency. And home field residents might have some more pre-existing relationships, both within the department or outside of medicine too, that can lend itself to a better social support structure. Furthermore, these residents might have a better understanding of the norms of the behavior or a better understanding of the system. We hypothesized that if there was going to be a home field advantage, this would most likely manifest an assessment of trainees' performance. We also hypothesized that if this would exist, it might be most pronounced in that intern year, where residents are experiencing quite a big transition from medical school to residency. So our objective was to examine whether there was a home field advantage in intern ACGME Milestone assessments for residencies who trained in emergency medicine programs affiliated with their school of medicine. We conducted a retrospective cohort study using a national database from the ACGME of all interns entering EM programs in 2021 and 2022. We coded graduates based on their home field designation. And residents were considered to be on the home field if they were a US allopathic graduate who matriculated into a residency program listed as their School of Medicine's primary affiliate. Everybody else was not on the home field or that visitor. We then assessed their ACGME milestone performance. We merged our data set with the PGY1 ACGME Milestone ratings for the mid and end year reporting periods, and we aggregated analyses at the core competency level. We then performed mixed effects regression and mixed effects logistic regression models to evaluate for differences in milestone ratings, as well as readiness for supervised practice. And ultimately, before we walk into results, I do want to just take a moment to make sure everybody's familiar with the ACGME Milestone competency domains, as I'm sure most of the audience in here is. In emergency medicine, there are 6 main domains, and all of these are broken into multiple sub-competencies that describe specific skills or proficiencies on which residents are assessed. This is an example of the grading scheme for the sub-competency of emergency stabilization housed within the domain of patient care. And you can see that the Clinical Competency Committee is able to rate the resident anywhere from level 1 to level 5, with that being synonymous with moving from a novice resident to that of an expert resident. If clinical competency committees do not believe that the resident is ready for supervised practice, they can select not yet completed level 1. So in 2021 and 2022, we had a total of 5,905 interns entering a total of 275 ACGME accredited emergency medicine programs. On average, 8.6 of those residents were considered to be on the home field. Ultimately, we found that these first-year home field residents did seem to demonstrate a home field advantage, particularly when it came to 2 ACGME core competencies. You can see that these residents actually did better on milestone ratings at the interpersonal communication skills at mid-year mark and patient care at the end-year mark. Furthermore, these residents were more likely to be ready for supervised practice. In other words, they were more likely to not be rated as not yet level 1, my apologies for the double negative there, both in interpersonal communication skills as well as patient care at the mid-year mark, but these differences did not persist through the end year. Additionally, when we reflected on the reasons why we thought a trainee might experience that home field advantage, we decided to analyze some sub-competencies within systems-based practice, because there's a few sub-competencies that pertain to a resident's ability to navigate the system for their patient's benefit. And what we found was that for sub-competency 3, system navigation for patient-centered care, these home field interns did better on milestone ratings at the mid-year mark. However, there was no difference with readiness for supervised practice. So in conclusion, our findings empirically demonstrate that a home field advantage does exist in the ACGME milestone competencies. However, it should be noted that some of these findings are modest and sometimes do not persist all the way through the end of the intern year. Now, why might this be? Home field residents might have some increased familiarity with the program, a better sense of their qualities. They might know some residents and faculty and have some pre-established mentoring relationships. They might also have a better understanding of the system, including the delineations of care and how different care teams interact within the hospital or what resources they can leverage in an outpatient setting too. And they might even have a better understanding of the EHR. Furthermore, these residents might have a better appreciation of the unwritten rules and the culture that dictates so much of our day-to-day in the hospital. And lastly, we can't forget that there might be a referee bias here too, and that members of clinical competency committees might have that pre-residency familiarity with these interns that can lend itself to a home field advantage in the milestone ratings. Our study, just like all, has some limitations. First, the home field designation was limited to that of U.S. allopathic graduates. Additionally, we did not include significant transition to residency experience, such as away rotations, and having those away rotators be considered on the home field. Very importantly, our data includes cohorts of interns entering into residency in 2021 and 2022. Years that we all know both undergraduate and graduate medical education were significantly impacted by the COVID-19 pandemic. And lastly, the period for reporting milestones might be insensitive to transition difficulties at the PGY1 mid and end year marks. So what do we want to do next? Our group would love to take this research and expand it across additional cohorts, particularly examining groups who may have been less impacted by the COVID-19 pandemic, and see what might happen if we consider those away rotating students to be on the home field. We'd also like to examine longitudinal performance to see if these benefits in the ACGME Milestone competencies persist throughout all of residency training instead of just the intern year. We'd also like to investigate underlying factors so we know exactly why this home field advantage exists, and this way we could better support all of our residents equitably. Thank you very much for giving me the opportunity to be here for all of you today. Here are my references. I appreciate it. Are we doing a question?
So, thank you, Dr. Haidu. There is time for questions. So if anyone has any questions, please go to the microphone.
Please state your name and your institution as well as your question.
Hi, so I'm Nicholas Ellis. I'm at Penn State. The question I have for you is, do you believe that this was truly a home field advantage in the sense that the residents that had greater familiarity with the program were rated higher? Or do you believe that this was the converse in the sense that the residents who were less familiar with the institution actually ended up being rated more negatively?
I think that's a really good question, and something we can only make some assumptions on, but I would say it would probably be the former, where these home field residents are doing better, particularly because we could probably consider that ideally everybody should be on the same baseline as they're coming into residency. However, they probably do have some skill set that lend themselves better to milestone performance.
Hi there, Stephanie Seabog-Sire from Stanford. Great presentation.
Thank you.
I want to maybe more comment rather than a question, but I'm thinking a lot about this work in the context of like what's next, right? How do we be 2 steps ahead? How do we use this for the educational good, right? So if you think about the home court advantage in sports, there's a reason why we don't play all of the games at one particular, court. So how do we build this into the training exposures that we give to our residents when they come in, knowing that somebody has potentially a home court advantage, at what point do we say, well, we're going to make you play on the away court now and see what sort of things translate and not. And I think, a really good framework for thinking about this might be like the master adaptive learner and building that and overlaying that on top of how we purposely use this sort of information to enhance education.
I totally agree with you. Thank you. Okay. All right. Thank you all again.
All right. Thank you, Dr. Haidu.